Good morning, everybody. Today I will be discussing a very basic thing, that is preoperative checkup. Anesthetizing a patient without a preoperative checkup is like traveling in an airplane without a pilot. Preoperative assessment is the cornerstone of perioperative care by the anesthesiologist. Relevant history, including comorbidities, the medications and past surgical history with associated anesthetic complications can be obtained during preoperative evaluation. This information can be supplemented with the findings of physical examination and necessary investigations to formulate an optimal anesthetic plan. Also, preoperative checkup helps the anesthetist to build rapport with and gain confidence of the patients. The preoperative checkup includes the following steps: preoperative assessment, pre-medication and instruction, assessment of airway, and plan for anticipated difficult airway. Preoperative assessment. It is done for the following: know about your patient's comorbidity and their functional status, which can significantly impact the anesthetic care. To optimize the patient for their comorbid illness before or elective surgery. To formulate an anesthesia plan by deciding the drugs to be used and the type of anesthesia. Stratify the patients. Take consent. It involves a thorough history taking and examination of the patient. History taking during the preoperative period is required to obtain information about the patient's medical, surgical and medication details, which guide the anesthetic management during the perioperative period. The history taking should focus on demographic details including age, weight, body mass index, that is BMI. Comorbid illness such as diabetes, hypertension, thyroid disorders, seizure disorders and coronary artery disease. Medication history, types and duration of each drug the patient is taking. Personal history, smoking, alcoholism, history of allergy, including allergy to any food items or any medication. History of previous surgical history of previous surgery by regional anesthesia or by general anesthesia. Family history. The unexpected death of a first degree relative under GA makes the probability of malignant hyperthermia high. The examination. Head to toe examination of the patient is done with an emphasis on the cardiorespiratory system. Abnormal findings in any organ system should be properly evaluated and optimized before taking the patient for elective surgery. The important head-to-toe findings that require further evaluation are as follows: central nervous system, whether altered sensorium or behavior. sensory or motor deficit, abnormal gait and cranial nerve pulse, cardiovascular system, irregular heart rate except for sinus arrhythmia. The difference difference in blood pressure of two limbs. This can happen in the coarctation of the aorta. Presence of carotid bruit and murmurs on auscultation. Abdomen, any lump or swelling. Presence of tenderness. Musculoskeletal system. Limitation of movement in any joint may complicate the patient positioning during the transfer and under anesthesia. Limitation of movement at the cervical spine makes the laryngoscopy and intubation difficult. Respiratory system, altered thoracic spine curvature, such as scoliosis. Presence of wheeze or crepitation may be due to lower respiratory infection. Breath holding time is commonly done to assess the cardiorespiratory reserve of the patients. The patients are instructed to hold the breath after deep inspiration, and the time is noted till the patient are able to hold the breath in the following manner. 25 or more seconds, good result. 25 to 15 seconds, borderline. Less than 15 seconds, poor result. The detailed examination of upper respiratory tract with its clinical implication has been described later on. After history taking and physical examination, risk stratification is done based on American Society of Anesthesiologists, that is the ASA classification system. Patients are classified under increased risk of morbidity and mortality by this classification. Thank you.